Good morning, Raj. Can you hear us?
Good morning, Bashir. Good morning, everybody.
Good,
Welcome.
Ours is good evening and
to
yours
you.
is good morning.
Yeah. Excellent, excellent.
C3 is a meeting which has been in evolution
Congratulations
for
on
I
last
think,
decade.
live.
There
Just
are many
wait, they're showing
conferences
your
that
video
are
first.
phenomenal, telling people what can be done, but there's a fundamental difference between faculty being able to do it and being able to teach those in the audience how to do a procedure.
This is demonstrating not just the most difficult cases, but also cases from a real life experience where we, in a real world practice, on a daily practice we are facing and we're dealing with.
It actually is a venue where people can come and really take back with them new treatments for their own patients.
I think what Raj has been able to bring to the table is much
Can I
more
ask Professor
international
Yaz Ahmed to come up
involvement.
here,
It's from
please?
Asia, it's
Professor
from
Yaz Ahmed.
Africa, it's from Europe, it's from America.
And these folks get the technology first. They're actually using these new devices, and what they do is demonstrate those new devices at C3.
The mission has still remained the same, is to share the best practices and techniques so that we can continue to move our specialty forward.
Dr. Raj,
Bashir, can you hear me?
yes, I can hear you. I just wanted to, before we start, I just wanted to tell everyone about C3. C3, Dr. Raj Dave has been running this C3 course for last almost 10 years now. And I've been part of C3 for last 5-6 years now. And I can tell you, I think considering overall, this is probably one of the best conferences I have been. It's very concise and to the point and very focused. And it's truly an international meeting. Faculty from all over the world is there. And it has been a true learning experience, and Dr. Raj Dave has been running that course single-handedly. Okay, Dr. Raj. So tell us about the case.
Welcome,
First of all,
everyone,
thank you very much.
to Hortensio Heart Center in Harrisburg. I'm going to give you a brief introduction of everyone who is here today, and I'll tell you a little bit about the patient, and then we'll show you what we are up to here. So to my left is my esteemed partner, Dr. Wali, who is very kind enough to come this morning to help us with the case so that I can do some talking while Andreas does some work, and then we'll do back and forth here. To my right is Karen Smizel, and we have several other staff members helping us today. So, if we can now show the patient history, that's my disclosure. This is a 61-year-old female. She's diabetic. She has hypertension. She has hyperlipidemia. And she was admitted at an outlying facility with unstable angina. She then underwent stress testing over there, which was positive, which led to a cardiac catheterization, which showed that she had severe LAD disease, she had severe dominant circ disease, and a non-dominant right coronary artery with an ejection fraction of 45%. So she was referred for coronary artery bypass grafting. She saw cardiac surgeons, and after review of the angiography by cardiac surgery, they felt the patient was a suboptimal candidate for CABG because of her anatomy of her LAD. So that's how she was referred to me to come see me for percutaneous revascularization. So that's the patient's history. Now what I'm going to do is to review the angiography with you. And once I review the angiography, perhaps then we can have some discussion about what to do with this patient. And we'll then tell you what we are thinking about doing. So you can see that the left main is good. The circumflex and LAD both are extremely heavily calcified vessels. The circumflex has 70% of stenosis. Distally, I suspect that the whole vessel is a diffuse disease. The OM branch also has 80 to 90% of stenosis. The left anterior descending artery has a severe calcified diffuse disease all the way from the proximal to the mid segment. So without even injecting dye, you can delineate the entire coronary tree. And this is the some of the pictures of this angiography in different views. And now you can see the extent of the heavily calcified tortuous LAD disease all the way from the proximal segment, mid segment, and a distal segment. So that's her anatomy. And we love to hear your opinion about what you would do and how you would treat this patient.
I think in Pakistan we're going to treat him medically. I'm just joking. Okay. Let me ask our panelists' views, Nadeem. So let me introduce you quickly to the panelists. We have Professor Nadeem Rizvi. You know him from National Institute of Cardiovascular Diseases.
Sure. Hi, Nadeem.
Hello, Raj.
General Azhar Kiani is here. He's from Rawalpindi. Professor Khan Shah Zaman, Professor Ijaz Ahmad, Professor Zubair Akram, and Dr. Bilal Mohyuddin. So, Nadeem.
Great. How was did Parag make it there safely?
Parag is actually doing a case at my institute right now. So, he was doing the live case from there.
Okay.
Yes, Raj, hello.
Great.
Don't worry,
So
Parag is being abused or misused. Since the morning, I think he's been doing a CTO, so he's okay. Yeah. I think it's a straightforward rotablation case because of the way, the extent of the calcification. I wasn't initially sure about the proximal LAD. It looked pretty okay, not really obstructive, but in the AP cranial view, there was a discrete tight lesion at the bend, I think, which we were missing on the in the caudal views.
I think it's not going to be that straightforward because that mid LAD lesion, the way it is, it almost looks like subtotal and severely calcified. I'm not sure where I'm going to start and where am I going to end putting the stents in after rotablation, because it's kind of a diffusely disease except that mid portion where there is a severe eccentric calcified lesion. But Dr. Azhar Kiani, what do you think?
Yeah, as you said, I think straight away medical therapy. And then instead of spending hours and then doing the rotablator and then showing the cost effectiveness of the procedure, go for the easy thing. But I think it's going to be a nightmare as far as the LAD is concerned. It's calcified to the distal and the multiple, I think, runs of the rotablation, and then it's very difficult, I think, to put the stent down into the LAD. So this is going to be a difficult case. But I think how symptomatic the patient was, and was there any objective evidence of the ischemia in this lady?
Well, patient is pretty symptomatic. She has angina with minimal activity. She's on 3 anti-anginal medications. She's on Ranexa. She's on calcium channel blocker as well as beta blockade. So she's very symptomatic. And with this type of disease, medical therapy is just not really going to do the trick. So as you suggested, it's absolutely correct. That's what our plan is. So it was very tough. We were doing some work on this artery before we came on live. So what we did here is, this is what our plan is, to perform the rotational atherectomy and practically stent the entire length of the LAD. That's what we are hoping to do, depending on how things go. We crossed this lesion with a BMW wire, and let me see if I can show you. And see, that's a Corsair microcatheter. So after crossing the lesion with a BMW wire, we try to put the Corsair through so that we can exchange for a rotofloppy wire, because we felt that with this much bending in this LED, it's going to be extremely challenging to cross this lesion with a just straight away rotor wire. So even the Corsair catheter had really difficult time getting through the entire calcified LED. But we were finally able to get the Corsair down and exchange for a rotofloppy wire. And now we are here, and we have a 1.5 rotor bar, and we are almost there. So Andreas Fluoro.
So Raj, I know
Okay.
you do a
And we're
lot
gonna
of
go ahead and
orbital atherectomy too. So any reason for using rota than orbital atherectomy? Is there any difference?
Yeah, that's a great question. So I'm going to work and I'm going to talk.
Okay.
You know,
That's
we want to
fine.
go in a little bit more.
Sure.
So this is a case where orbital atherectomy will not do. Andreas, let's pull back a little bit. Okay.
I don't think there's much disease.
Yeah. Okay. All right.
You give us a puff of dicam.
Yeah. Yeah, we're right at the lesion.
So you want to
Yeah.
come back a little bit?
This is fine. Let me try. So with this type of lesion, the orbital atherectomy device will not cross. Fluoro, please.
We're low. Calm down. 150.
So in this situation, we would prefer a rota because with orbital, you need a little bit of lumen, Bashir.
Okay.
Because if you don't have some lumen, the bar is never going to go through.
Turn it down. Turn it down.
So you,
Paula.
I've taken a 1.5. So I've gone through the proximal lesion really hard in the mid segment here.
so what burst speed you are at?
We are at 160,000 RPM. And we're 20 seconds into it. So we're going to give a little bit of rest to the vessel, and then we're going to continue further down.
So you started with 1.5. Why not 1.25?
Well, the artery is huge. So, you know, I think that, you know, we could have started with a 1.25 and nothing wrong with that. But we thought that 1.5 is good sizing here.
So you are going to stent from apex to the ostium?
So this is the packing.
We're losing wire.
Yeah, I think the wire is okay. I'll fix
Wire
it.
is coming
I'll
back.
fix it. Yeah. So what I'm going to do is I'm going to fix the wire a little bit here.
And do them for rotor on dyno.
Yeah. So we're going to use a Dynaglide to push the wire in a little bit. Okay. I think it's.
Okay, let's just
I think that's
reposition
not
the
bad.
wire.
Yeah, that's not bad. Okay. All right, let's
Got
push
the
the
wire?
button. Yeah, wire's okay. Yeah. Okay, that's good right there. Okay. Off dyno.
Because that thing is pretty tight there.
Yeah.
I would just-
So Bashir, in this case, one of the biggest risks would be stuck rotor bar.
Yeah.
And that's another reason to not use a very small device. Because if you use a very small device, you increase the potential risk of stuck burst sometimes also. So
Let's come back and rest that.
I saw in the beginning you were keeping it at one place for quite a while. Are you looking at the timer also, or?
Little puffy.
yeah, we have a timer and we also have a speed.
Okay.
So that's good. I'm going to store that fluoro run here.
What
What is the size of this rotaburr?
1.5.
Oh, let's just take a picture. It's fine. Go ahead. Yeah, so far so good.
Yeah, looks nice.
We still would like to push the wire down a little bit further. So I'm going to try to do that again.
So you will do up to like almost where that marker is?
Yeah, we want to go all the way in the mid segment, if possible. Yeah, the wire is so bent up into the
That's fine.
artery.
That is not that calcified.
Yeah. Okay,
Just
we'll make
polish
one more polishing run here.
So are you going to go with a bigger burr also or just leave it here?
No, this bar is enough. Okay, so a little bit of a risk, but I've taken it all the way into the mid segment.
Would you like to use some cutting
Andreas,
balloons
are
at
you
the tightest
satisfied?
point?
30 seconds.
Probably not. He's just going to use NC. Once
Pick
it's
it up.
rotablated, then there's no point of using cutting balloon. Cutting balloon won't
Give us
even
a
go
little
through
puff.
this.
Because the point which is the tightest point, it probably needs something more.
No, NC, they will take the NC balloon and dilate it. If that goes, you dilate it, that's okay.
Yeah, so
Otherwise
what we
they
are
can-
going to do is we're going to dilate with the NC balloon. Then we're going to do an OCT run.
Yeah, if they are unable to dilate with NC
So I'm
balloon,
gonna
then they can take a
dynaglide
bigger
the
burr,
burr
but
out.
cutting balloon won't go down here.
Yeah, I would not recommend cutting balloon for this anatomy unless you want to perforate the vessel.
Now, so with regards to the using a larger burr, you can stop. Yeah. We're going to do OCT, so we can measure the thickness of the calcium. If the calcium is less than more than 500 microns, then we can decide
Absolutely.
to use a bigger burr.
So
So
if you
the-
want to do an OCT, we should let's do one picture now so we can see if the OCT catheter will go through. Yeah, a lot of spasm.
Yeah.
At least we can just do the proximal OCT. We don't have to
So
do the distal.
what anticoagulation regime you have used?
In this case, we would 100% use heparin, Bashir, because this is a potential risk for perforation. So we want to have the ability to reverse the heparin if necessary. What I would recommend, Andreas, is that we change it over to a regular wire and balloon it, and then we will do the OCT.
Sounds good.
Let's do.
And
I don't think we need a bigger bar.
And antiplatelets?
Do you want to
you
talk
you
about
using
why OCT?
ticagrelor now or?
Yes, ticagrelor and aspirin.
Okay. So that's your routine in all the patients now?
No.
In acute coronary syndrome patient, based on the Plato trial, we used ticagrelor.
Okay.
So this patient's presentation was ACS when she had her diagnostic angiography. So that's why we recommend ticagrelor. We also have an option of giving cangrelor if necessary, which is an ultra short acting antiplatelet drug, which can be given with ticagrelor.
It's been 30 minutes since your heparin.
Yeah, can we give 2,500 more? Yeah. So now you can see
So-
how
so,
easily
yeah, it
the Corsair has gone down.
It went down very nicely.
So I think I'm pretty satisfied.
Can I have a 2.5 trapping
And what
balloon,
wire you are going to
2.5,
use? Are you going to
15
use any heavy support wire or just a routine wire?
BMW.
No, we like actually using BMW wire, and we actually think that the heavy wires in these type of segments actually fight against you. So may I have a Mosaic 30 by 17 balloon? We're going to use a trapping balloon to get the corset out, and then we're going to dilate with a 2.5 by 30 Emerge NC. So I need a Mosaic first.
Just for trapping.
For trapping, or any 3.0 balloon.
1.25.
So
we
you
have a
have-
7 French guide, so we need a 3.0 trapping.
So you have Absorb available in US now, so would you be thinking
Yes,
of
we
using
do.
that? Not
Yeah.
in this one probably.
Yeah, we want to do absorb here. if we can properly dilate the vessel,
Yeah. It will be challenging to get the
What
absorbed
size is
down
this?
here.
This
Maybe
is
in
a
the
304
proximal segment,
trapping.
but distal may be difficult.
Is there any role of an absorb in a calcium calcified vessel?
530?
yes.
I think
Because
Probably it doesn't
the whole
make much of a
concept of absorb being that once the stent gets dissolved, the dynamics of the vessels will be restored.
Yeah.
But once you have got such badly calcified vessels, which starts virtually from the ostium, I wonder really if the dynamics will be restored
I don't know
to
if
that
there-
extent.
I don't know if there is any study or anything showing in calcified lesions. At least I'm not aware.
So the only anecdotal evidence that I have about this is that asked this to Antonio Colombo, and he said that you'll never find out unless you do it.
Yeah, that's right.
My concern is that, if we are going to stent this entire heavily calcified vessel, how long is it going to stay patent?
Again?
Any idea?
Okay, we'll take that balloon.
Raj, there is a comment from the panelists that if you are going to just metal jacket this whole LED, how long this is going to stay patent, or what will be you will be quoting the risk of restenosis to the patient?
I think that the restenosis risk here is no more than 5% with either a second generation drug-eluting stent or bioresorbable stent, given that we're going to do proper preparation of the vessel and a proper implantation with a proper expansion of the stent and apposition. So all of, the key to the success of this type of procedure, in my opinion, is the best preparation, the optimal stent implantation with the image guidance and a proper medical therapy. So patient is on a high dose statin, beta blockade, dual antiplatelet therapy, and as good of a job as we can do. And we have very nice results, because if you look at the Impella 2 trial, these type of patients, those who were surgical turndowns with LV dysfunction, were enrolled in that study. And if you look at the outcome of those patients, including target lesion revascularization rate, was very low. So this patient does not have an LV dysfunction, so we do not have hemodynamic support for this patient. However, the anatomy would be very, very similar to what we would have seen in a Pella 2 trial, and it's an ideal situation for that type of a procedure. So let's do a picture here so that we can make sure that we have the balloon in the right spot. So this is a non-compliant.
I like it.
Yeah.
I'm just going to push it forward 1
Yeah.
millimeter.
And this is a 2.5. I've picked a 2.5 for a distal. And
we do low pressures post angioplasty, a post rotoblator.
so this is a 14 atmosphere. And you can see there is a nice expansion.
So you think the notion of the longer the stent, higher the risk of restenosis doesn't
Yes,
hold true for DES, and you can put as long as you want?
Well, I think that Bashir, what other alternative does the patient have?
Yeah, no, that I agree. But I'm just saying, I think I was kind of a
So,
little bit.
we send the patient for surgery,
Yeah,
right?
no, I
There is
agree.
no
But I
surgical
was just
segment
saying, I
in
was
this
kind of a little
LED.
bit disagreeing with you said 5%. I'm probably with that long, if you put 2 or 3 stents here, the risk of restenosis probably will be more than 5%.
My other question would be that what objective evidence is that the LED is the culprit vessel, because the circumflex also has an ostial as well as a mid disease,
Stress test.
and it is also calcified. So
Well, patient had a stress test before, remember?
Yeah, sure, stress test. And there was-
stress test.
Patient did have a large
which
area
technique?
of ischemia,
Anteriorly.
anterior ischemia on a stress testing.
Myocardial perfusion imaging.
Okay, so now we have done the balloon, and we're now going to go ahead and do the OCT. And then based on the OCT, we'll start implanting some stents.
For OCT, what is the minimum lumen that you must have to take the?
But OCT is not good. So it's going to just help you to basically size the stent, because it's not good for the calcium.
Actually, it's very good for calcium.
That is the best for the calcium, you know. There is no other better device than calcium, because with OCT, you can see plaque behind the calcium. Also, you can measure the thickness of the calcium, and you can clearly delineate the calcified globules around the vessel. So that is the best device. So in a calcified lesion, we always use OCT. With IVUS, because of the calcium reverberation, that you get the artifact and you cannot see anything behind the calcium. So, but we're going to show you live, so you're going to be able to see it. So,
but what is the minimum lumen that the OCT tube has to have?
In terms of, you know what?
Really, the only issue is whether you can get contrast past. So we've burred with a 1.5 burr. That's a minimum lumen, we know. So we should be able to get some contrast past the catheter.
So we're gonna if you want to measure the evaluate the distal, we can push further.
Yeah,
Keep pushing. Let's see if we.
Let's just do here.
Yeah, I think proximal LED is
that's where
fine.
the calcium is. Yeah.
So, can you see the OCT screen? And hit auto calibrate. Okay, very nice. So we're going to do angiography and OCT at the same time. So we don't need to do anything with the catheter. Don't need to touch the catheter. Step on the cine. Inject. Beautiful. Beautiful. Okay. All right. So what I'm going to recommend to Andrea is that he dilate this artery with a 3O non-compliant balloon also, while I review with you the OCT run, and then we will see if we can start implanting bioresorbable stents. So we can take the OCT catheter out.
3030 NC.
3030 NC, you guys.
So this is in the mid LED where you are seeing now. So this is contrast artifact here. This is wire artifact, that's normal. This is the catheter, this is the surface of the vessel. And we're gonna go until we start seeing. So this is the balloon angioplasty result here. Dissection from the balloon. And now you're beginning to see the artery fully. This is the wire artifact. This is all the surface of the vessel. Huge atherosclerotic plaque burden. So you can see this hypodense area. Now you see this severe concentric calcification. So you don't see it as well in this particular view, but I will show you some other views where you'll start seeing here's a calcified rim in the deep wall of the artery right there, which you would never see on IVUS. You know, this looks like the artery is very nicely decalcified. Another wire shadow dissection plane. These are all dissections from our balloon. And the proximal, this is now the proximal LED, the circumflex coming here. And this is a true distal left main and a huge vessel. This is a proximal LED up to here. So just for the sake of it, if I measure this, it's already 60 millimeters. So we know that we need at least 3 30 millimeter or so stents to treat the entire vessel. So by looking at this OCT, there are two things that we learned. One is that there is no severe calcified plate now in this LED that requires us to do additional rotoblator. And we realized the size of the vessel. It is a large artery.
Again. I just want to get that rim there.
So
one of the concern here with the bioresorbable stent will be whether we can advance the bioresorbable stent in the distal segment. We may have to use a guide liner, but we are prepared to do that if necessary.
So this is 30 NC or 25?
That was a 2-5. We're going with the 3-0. We just did the distal with a 2-5. We're going to do the more mid and proximal with the 3-0.
Okay. So if let's see this NC wouldn't open the artery up, then you will go with a bigger bar, or what will you do?
Absolutely. Then we would use a 2-0. So quite frequently, when we do OCT runs after the first rotational atherectomy run, we find that there is heavy remaining calcification in the vessel, and we may have to upsize the bar. So when you do OCT guided rotablator, which is what this case is about, we find that we always upsize by 0.25 sizing in comparison to what you would have otherwise chosen by doing just a naked eye evaluation. So just like yourself, we also thought that, oh, well, you know, this might be a good one for a 1-5, and then we can upsize. So we learned from the experience of doing OCT guided rotablator that if we think it's a 1-5, we should just go with a 1-5 because we almost always upsize it. So that's a 3030 non-compliant balloon.
Looks expanding nicely.
14.
Good, 16.
Any questions or comments from the audience?
It looks
Now,
like,
if you're
looks
planning
like the
to bring
balloon
it
is
to
expanding
absorb,
appropriately.
The rule is that you have to always size it 1-to-1, definitely. Now, once he has ballooned the vessel, and it is a calcified vessel, would you like to do an OCT pre-implantation to establish whether you have got the required lumen? Because that stent doesn't have the strength to push it up.
I think that's what he did OCT after balloon inflation.
Now he's doing ballooning it again.
In the proximal portion, yeah.
So will he do an OCT again?
I think he's doing it with 3-0, so he's probably going to put 3-0 proximally and 2-5 distally.
Using a 3-0 balloon doesn't really mean that you have attained the 3-0 size.
Yeah, but we have the OCT which shows even a bigger than a 3-0 lumen already. So we know that this vessel can easily take a 3-0, maybe even a 3-5. So once we put the stents in, we're going to post-dilate it with an even larger balloon. So let's do one angiographic run, Andreas, now. Looks beautiful. So I would say we can start from that very distal diagonal branch up, back up.
I would pull the wire a little bit back before it really goes somewhere and...
Let's hit BMW.
Yeah, I think it's okay. We're not so worried about the wire.
Okay, so
we just had one
I'm just worried about
yesterday.
the calcium in that distal segment. Whether to put a
What is your opinion regarding the smaller diagonals arising within the from here when you're taking up these heavy struts stents? Do you think that these vessels need to be tackled prior?
No, I think these are too small to do anything. I wouldn't worry about these.
Good question. Good question. So what we would recommend, you know, by look at your data from the EPSORB 3 and EPSORB 4. So in EPSORB 3 and EPSORB 4, the bifurcation was allowed provided the side branch was less than 2.5 millimeters and did not require any intervention. So in this case, you know, both the diagonal branches are less than 2.5 millimeters or barely 2.5 millimeters. And we would not really, regardless of whether we use an EPSORB or a bare metal technology, we would not go after those branches anyway. So what we are debating, however, here between me and Andreas is that whether we should start with a metal stent distally and then do EPSORB in the mid and the proximal segment, given there is still fair degree of recoil of these stenosis.
Yeah, probably
proximally,
because
I feel
at the origin of the second diagonal, it has a lot of recoil and it's still plenty heavily calcified. So that may be an idea. But then if you are going to use one metal, then why have other as absorbs? You should have the whole absorb one, because that will give you the advantage later on.
Yeah. The concern is that there's less
radial strength
with the absorb. So if you look beyond the second diag, down where just before the vessel tapers to a small section, there's a hunk of calcium there, and I'm not sure that we got that as well. I'm worried that if we put an absorb stent there, it will not expand as well.
Yeah,
It's,
totally agreed. And then again,
the
because
balloon did
if
expand.
you feel that later on that you need to go through and open up these diagonals, if they get compromised, it might be easier to go do through the metallic stent rather than the absorb.
Yeah, but these diagonals, I
Yeah,
don't know,
so
it's
let's
like
just
less
go
than
with
2
a
millimeter.
2.5 by
I wouldn't
38,
be worried
you
that
know,
much. Even if I'm putting
or
a
2.5 by 28.
metal stent or other one,
Alpine.
I wouldn't even wire them or do anything to that.
So do you want to still do
Well,
the
probably,
absorb proximally? Or?
Yeah.
Because if we want to do the absorb, maybe we should do a short metal and then...
Yeah, so 2.528 Alpine, and then absorb from that point
So-
on. Okay, may I have a 2.5 by 28 Alpine, please?
Is that it?
Yes.
Yep.
That's what I like.
So you are going to use a regular desk down there, huh?
Yeah, in the distal part.
Okay.
And then from that point on, we will do absorbs from that on.
So Alpine has which drug on it?
It's a Zions.
It's everolimus, same drug which is on Promus, Alpine, as well as Absorb.
Okay.
Now the reason why we like Alpine is because Alpine is on a non-compliant balloon. So, beautiful, beautiful. Okay.
Hold on, hold on.
Yeah, may need to go a little bit more.
Have to go down.
I think that's okay.
We need to make sure we're there. Give me a
they
perfect. I
using
think we're
wire
just shy of the
absorbable
lesion.
stents or second
And that's the
generation
segment.
stents?
Maybe-
I'm sorry?
maybe we need to-
Which stents they are using?
This is Zions, Alpine.
This is a Alpine drug elution, which is Zions family. This is the latest Zions.
What is the difference in its trackability as compared to the regular Zions? Does it have a different?
It's a much better, right? Because the Alpine has a tip on the balloon that's tapered that allows greater pushability.
Okay.
Yeah, but your catheter is jumping out like anything. So
Down as far as you can.
Okay. It's almost there, but it's coming back.
Okay, we'll
Let's
start
try.
it
I
here.
don't want
She's
to.
the size of the stent?
We should dilate it. Let's
Either
dilate
it or put a synergy or something, but or shorter stent.
Yeah. Okay, let's take this Alpine out because it hasn't gone as far as we want it to go.
Give me a little puff there. Yeah. Wait.
Yeah, we need a little bit more. So let's try a 2.5 by 20 Synergy. So Synergy, as you know, has a thinner stent struts. So we're going to try that to see if we can get it across that particular stenosis. Yep.
Do you want us to use like we'll dilate it one more time with a shorter balloon or the endoscope?
I think that.
Just try and get
Let's
it
try.
up. Just hold on to that. Yeah, don't lose it.
So now you can see that, that we had not gone that far down with the Rhoda, and now we're paying a little bit of price for that. But let's see if we can get away with this thinner strut stent so we can get down there.
You have the luxury of doing that. If one doesn't go, you take another one. If that doesn't go, take the third one. But we don't have that luxury.
Well, we just rotoblade it, if if it has to be.
Yeah.
Okay,
I
looks
think I
like
have
it
to
went.
Dilate more.
No, it looks good. We got it.
No, I think you still have to go down, no?
Take a picture.
You want to take a picture and see? It seems like
same place as before.
you need to go a little bit
Yeah.
more.
Yep, we're gonna try. Okay, well, looks like it went.
One more
Yeah,
millimeter.
just 1 more millimeter. Okay.
Hold on. Let me just look right. Last thing we want to do is just make a little puff.
Mm-hmm. Bam. I think it's pretty good.
I think we'll just miss the tip. I'm worried that we just.
That's pretty good, Andreas. Stay right there. Yeah, I think it's pretty good. I'm going to deploy it here. So one of the things about Synergy is the Synergy is not on a non-compliant balloon, so we should not go too high. But I've still taken it up to 14 because we had gone pretty high on the non-compliant balloon. So we're going to pull the Synergy balloon back and dilate the proximal edge of the Synergy. Okay, right there. Andreas, do you think we can get it absorbed down there?
I'm not sure. I think we might.
We can try. So can we have a 30 by 28 absorb? Okay.
Now when you want to bring an absorb in, how are you going to overlap it with the metal stent, or is it just going to be the same edge to edge as the absorb is advised?
Same thing that we would do with an absorb overlap with each other. So we're going to put the marker to marker there, marker to the edge of the metal stent. Yeah. And if it doesn't go, then we'll just use metal.
The absorb stents, are they recommended in complex lesions?
If you can deliver it, it's fine. The main problem with the complex lesions is it's a heavy profile and it's not easy to deliver down.
Well, if we can't deliver it, we'll take it out.
Otherwise, it shouldn't be a problem.
Studies done on these scaffolds have never been on complex lesions. Have they been on that?
I don't know about calcified lesions, but I think complex lesions, if you can deliver the stent, that should be all right.
Yeah, so this is what I was worried about. So we can see that we have difficulty delivering the absorb. Let's just take the absorb out.
Let's take that 2.5 stent we have.
So can let's use the 2.5 28 Alpine that we have. And we continue with that. So we already have that stent open, so we'll just use it.
Now Raj, there's another question is that now once your absorb is out of the packet and it has gone into the catheter, your time clock starts. So, because it has now touched the blood. So, can you sort of take it out and then retry it?
No.
No, we can retry it in the proximal segment. It's good for, several minutes.
No, but the same stent, because the same stent has been exposed to the blood, and they say that once open, it should be deployed within 5-6 minutes, stuff like that.
Yes,
sure.
Bashir? Hello. How
Sure.
good is absorb in a calcified lesion? Do you deploy it
That's
there?
pretty good.
I'm sorry?
How good is an absorb stent in the calcified lesion?
There are concerns which they just mentioned that sometimes it's possible because the radial strength is not much, so it may not open that well or stay open. So calcified lesions.
Yeah, we're not gonna push our luck.
So
now we're gonna measure it with this balloon that how long of a stent we need in the proximal vessel here. So another 28 will do, right?
Which one has he used now?
Alpine, the one he opened earlier.
Okay.
Yeah, may I have a 30 by 33 Alpine?
Would you like to use where your balloon was to redilate it, and then since your absorb is already out, try it again?
Well, I think that, these are, some of the judgment calls, and you should also think about radiation, exposure, contrast volume, operator fatigue, time of the procedure. So I think we gave it a try. I'm pretty satisfied with, second generation DES here, because we don't really want to push it, things that does not want to go properly. But we knew that from the very get-go that we may not be able to. But we gave a college try, and I'm happy about that. Okay. Okay, stop. Okay, Andreas, let's see. Oh, you're very easily inside the stent, no problem. Yeah.
Tough again? I don't want to be it.
Push in a little bit. That's good, yeah. Okay. Okay, so this is a 22 atmospheres. on Alpine. This is one of the advantages of Alpine.
3030 NC balloon.
Yeah.
3030 NC balloon.
Emergency 3030, new one. Yeah.
So
Okay,
you
let's
came
take this,
almost up to
stent
the
shaft
ostium
out.
of LED?
No, proximal LED.
Proximal LED, okay.
Yeah. So we're going to post dilate the stents, and then we're going to repeat the OCT so we can show you that what actually it looks like. I promise you it's going to look great.
That goes without saying.
Any 30, any 3025.
3025.
3027, bring it, yes.
Yep.
We should also get a 3025 for the, 25
we're going to
for
go
the
all the way
distal.
down. Yeah. Distal we're going to dilate with a 3 also. But not
Worried
at the
about this,
edge.
Yeah, that's the thing. Maybe
Yeah.
for the edge we might need
Yeah,
a
just an
25.
overlap. Yeah.
So how long you are going to continue
So-
on antiplatelets on him?
1 year, 1 year.
1 year?
With a second generation drug-eluting stent, Bashir, when we do OCTs on these patients in the follow-up,
Yeah.
we rarely ever see any exposed struts. You know, they're all healed. So, you know, the length of, okay, that's good. Length of the lesion and the length of the stents really does not necessarily drive our DAPT.
Okay.
Okay, so that's a 3O non-compliant balloon at 18 atmospheres. I'm going to need a 2.5 by 20 non-compliant balloon also.
What would be the choice of the DAPT? Which ones would they be choosing in this case?
In the ACS setting, ticagrelor and aspirin. Non-ACS setting, you can use clopidogrel and aspirin.
Okay.
Did the stress thallium also show any ischemia in the circumflex territory?
No.
No, so that was okay.
Yeah, we're planning to fix
Yeah, we
that.
have to treat the circ also. It's a dominant large vessel.
Only debate over here always is that, you know, the stress thalliums come up with relative ischemia, and the one which has always more ischemia.
Yeah.
So with that kind of a circ, do you think in reality there might be some
Hold on,
ischemia
let me
over there?
see it, it's fine,
And would you
it's
like to, or do you in your practice repeat a thallium scan to see if this procedure
No,
has
we
made a
would
big
do an
benefit?
FFR for this.
No, this will be something that we can check with an FFR, but you know, in such a large, dominant, huge circumflex coronary artery, you know, there is no question in my mind with this much myocardial territory involved that the FFR will be less than 0.8. But if you want to be absolutely purist, you can do it. But I don't think it's necessary in this case. We would just go ahead and the OM branch is already 90%. There is no FFR data in that kind of a critical lesion, right? All the FFR data is in an intermediate stenosis. So why to do an FFR with the lesion severity is that high? So this is a 2.0 non-compliant balloon, and we're going to dilate the distal stent with a 2.5 non-compliant balloon.
Just want to see if I'm at the edge of the stent.
Yeah.
1 second.
So Andreas is going to properly position it for me.
Perhaps. This thing is stiff.
30 minutes since it happened.
Another 2.
It is very stiff in there. I don't know what's going on.
There you go. Perfect.
Hold on. I moved it.
That's beyond it. Yeah, right there. Okay, good.
Just be careful. Can we?
Okay,
give me
so
an
here
ACT
I'm going to
syringe.
keep 30 seconds, you know, inflated for 30 seconds to make sure that we have a good stent apposition there. Still a lot of calcium in the distal vessel. Okay. Okay, so let's take one picture and then we'll do the OCT.
I'm going to just puff through to make sure there's contrast ready. Okay.
Okay, so let's give some nitro while I get the OCT catheter on. $400 will be fine.
Do you want to hold the wire?
Yeah. I got it.
Raj, over here, we have a lot of fellows sitting over here also. For their learning, etc.
Sure.
When we start off doing these rotas, we are always basically recommended to just go for a short lens, not go for big lens. Keep it under 20 mm.
Yeah,
Over here, you have done dilatation of a very long length, something like about nearly about 90 millimeters length. You have done a rota over here.
Yep.
So how do we justify this when we are saying that you should avoid going above 20, and because there's a big difference between 20 and 90?
Yeah. So what we do is that this is a situation where patient does not have other better alternative, right? So these are all surgical. Okay, so that's far enough. Let's just give a little nitro. These are all surgical turndowns. So
Karen,
about 10%
diluted
of
or
our
not diluted?
practice here
Is it
is
diluted or not?
It's diluted. Yeah. Is patients those who have had some form of a surgical turndown. So this is classic PELA 2 trial patient where we would see, one second, okay, auto calibrate please. So if you look in the center of the catheter, there is some contrast. So Andreas is just pushing the dye out, okay?
Just give us a little contrast because we had saline.
Yeah.
We injected.
Yeah. Okay, that's good.
Okay.
Yeah. Okay, 1 second. So Cine and run at the same time. Cine, inject. Okay, so now you should be seeing the OCT live, and you can see the stent is perfectly well opposed. There is that aneurysmal segment that you were talking about. You are seeing that.
We have to do the proximal.
Oh, we're not, this is all distal.
Yeah.
There is an oblongity and tortuosity of the vessel. So at certain places, you might feel that the stent is not fully opposed, but that's not true. That's from the vessel dilatation and aneurysmal segment. But you can see that the stents are perfectly well opposed. No malapposition so far I've seen.
And it's well expanded, which is what
In a perfect lumen. This is more in the proximal segment now. And that's your proximal LED proximal to the stent, and that looks good as well. So I think that, in my opinion, in this extremely complicated artery, I would not do anything further.
Perfect, right? But
so now what we will do.
Can you show us the stent outlet first, please? The last stent's outlet.
Well, we did not push the OCT beyond the stent, the most distal stent, because of the potential of damaging the apical vessel. Because remember, OCT catheter beyond the imaging segment has a leading edge, but here is the most distal part of the stent where you can see no edge dissection here, and you can see few struts here. So we did not push it way past it, but it's fairly far enough. So I think this is acceptable now. We were going to allow the distal vessel to remodel. We have no choice, about apical LED. We're not going to be able to do anything about that. And treat those segments with medical treatment.
And the diagonals are still there.
And all the diagonals are patent. Yeah. So now let's review the circumflex angiogram. Our plan is not to do the circumflex today. Our plan is to do circumflex in a stage fashion, but while we are here, let's discuss it that whether you would consider rotational atherectomy of the circumflex as well, and whether you would consider rotational atherectomy of the OM branch, because the OM distribution is also huge.
But what is the lumen size of the OM? And it's quite
It looks like
curvy.
it's a 2.5.
2.5 to 2.75.
Well, it looks less to me than
It's
2.5.
quite eccentric calcium in the mid circumflex and OM also, so probably I think it would be, if you do it, if I do it, I would do it both on OM and the circ. Although you will need probably
So
a bigger bar.
I mean, I think that looking at the OM, one of the concerns obviously with the rotational atherectomy is the angle, angulation,
Yeah.
and size of the vessel, which I know we're looking. I'm sure that vessel is a little bigger. So we might not, I don't think I would definitely say we had to do a rotablade of the OM, but I think the mid-circ, as you mentioned, that definitely needs a 175 burr to remodel the calcium, to allow us to break the calcium and stent it. And I think that would be a much more conventional rotablader because it's, as you said, a short segment. But I think that with your comments with regards to fellows, I think that it's correct to say that they should start small. You do not want to start doing your first 100 rotabladers with a 90 millimeter vessel, that's for sure.
Definitely, you need
But
to
now
start
you also
simple.
need to explain that why in LAD you only used a 1.5 burr while you are willing to use a 1.75 burr in the circ.
Because we were trying to minimize the amount of, so we wanted to go more distal, and we believe that the distal LAD is smaller. If you look at the circ, this circ looks like it's at least 3.5. So we want to get more out of it.
Debulking,
We
yeah.
figured that if we had to, we could upsize from 1.5 to 1.75 or 2 in the proximal LAD if that was needed, but it
because
wasn't needed. As we
I
can
think-
see, we could expand the vessel.
The leon is not that tight, so 1.5 may not do anything. So just pass down. So probably we need a bigger
That's
one.
right. That's right. So you need a big one.
And what about the ostia of the circ? Are you okay with it, or you intend to do something over there
No, I think
also?
osteo is okay.
The osteum does not have much in a way of
Yeah, I
disease.
wouldn't
I
be
don't
worried
think there's
about that.
anything needs to be done with the osteum. Yeah.
And in addition, we always image, so we will know when we're doing the intervention if there is a problem with the osteum, and if there is, we'll take care of it on the way out.
Raj, we are, I think, reaching almost end of our transmission. It's absolutely phenomenal case. Thank you very much. I think it was a great learning case. And again, on behalf of all the organizers at Pakistan Society of Interventional Cardiology, I would like to thank especially for sponsoring this transmission as well. And I think hopefully we'll be having more interaction, Pakistan Society of Interventional Cardiology and C3, and have more sessions in the future as well.
Well, we also like to thank you for giving us the opportunity. I'd like to welcome all our colleagues to C3 in June this year. You're going to see a lot more of this that we just showed you. So thank you very much. Have a wonderful evening in Pakistan. And thanks to Dr. Wali and my staff who's done a
Yes.
phenomenal job to get here very early today to get this set up. And thanks also to the patient to allow us to transmit her extremely complicated and a high-risk procedure live. So thanks again and have a wonderful evening.
Thank you. You too.
Take care.